Welcome, everyone. Thank you so much for registering and for turning up this evening for the webinar with Professor Craig Shimasaki from Moleculera. He's the CEO of Moleculera, the laboratory that exclusively does the Cunningham panel test for Pandas, also called autoimmune encephalopathy. And he's a scientist with over 33 years of clinical diagnostic and therapeutic R&D experience. He started his career at Genentech, and he has been involved in the research, development, and clinical testing of neuropsychiatric drugs and diagnostics, genetic testing for the predisposition to non-familial breast cancer, a GP120 HIV vaccine, and RSV diagnostics and therapeutics. He co-founded Moleculera Labs with Dr. Madeline Cunningham, which is an autoimmune neurobiology clinical laboratory based on over 20 years of her research on infection-triggered autoimmune disorders. Professor Shimasaki's focus has been to translate basic research discoveries into acutely needed medical products for patients who need them. He's led multiple clinical diagnostic tests through FDA approval and is co-inventor on several medical and diagnostic patents. He has authored and edited 2 books, and he received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University Kellogg School of Business. So without further ado, over to you, Professor Shimasaki. Thank you very much indeed. Could I just mention, by the way, that if you'd like to make comments or ask questions during the course of the talk, please click on the chat button at the bottom of the screen, and not Q&A, because we'll be gathering everything under that chat button. And he'll be speaking for about 40 minutes. And after that, we will answer all the questions, or as many as we can get through live. Thank you.
Okay. Thank you, Jillian. Can you see my slides now?
Yes, absolutely. Can do. Thank you. Okay,
very good. Well, it's a pleasure to speak to you all. Good afternoon in the United States. Good evening over in the UK. I'm delighted to be able to share with you some interesting research and information about a broad topic called autoimmune encephalopathies. And thank you to AONM, who's been our partner in the UK and has been providing different types of educational forums. So I look forward to visiting with you more and talking to you a bit more about how the panel that we run here at Moleculera Labs plays a role in these various types of disorders that are broadly classified into these autoimmune encephalopathies. So with that, let me just share with you a little bit about, to make sure that this thing moves. Are we seeing the second slide, Julian?
Not yet, Craig.
Okay, let me see. Share screen. Okay, is it moving now?
Absolutely, yes.
Okay, very good. So I want to share 3 different sections with you. One about autoimmune neurology-based disorders and what we might call emergence, or really it's a reemergence of medical and clinical relevance, because many of these disorders and things we'll talk about have been historical, and you'll see that there are many medical models that actually tie into these different types of disorders we'll talk about. One specific topic that I want to talk about that has of interest is called molecular mimicry. And the reason that that is important is because it also is a mechanism that is understood to be a trigger for many of these chronic disabling disorders. Then secondly, what I want to talk about is the clinical presentation of these autoimmune encephalopathies. And we'll focus a bit more in particular on pandas and pans, and then the nomenclature, and then even the alternative nomenclature that's coming up in how to understand and identify really what the root and etiology is that they're talking about. We'll talk about the mechanisms for these conditions, and we'll talk a bit about some of the infectious triggers that are pretty common for these different disorders. And then I want to talk about the anti-neuronal antibody targets that are in the Cunningham panel, and then why these were biologically significant and why they were selected. And then importantly, show you not only internal case studies, but published case studies, and then a manuscript that we've submitted and in a review for another 62 patients in identifying the connection between these symptoms and these anti-neuronal antibodies and their presence. And then at the end, I'd like to summarize a little bit about what to take away from this. And then there'll be time for some questions and answers. So this broad subject area called autoimmune neurology, it's really just the interaction between the immune system and the nervous system. So the immune system and our knowledge of the immune system really has been gaining interest over time. In 1983, I was working at Genentech, and HIV actually occurred during that time, and there were cases that were being identified. At that time, it was really difficult because immunology was really not significantly different than what it was many, many decades before that. Since then, there's a lot of immunology understanding for its use in cancer and other types of therapeutics. But just briefly, we have both an innate and an adaptive immune system. And as you can see here, they take effect at different times. Our innate is very quickly assimilated against foreign invaders. And then over time, our T cells, our B cells, our antibodies, and then what we'll talk about even more is those that are involved in the brain. And this interaction then is the immune system begins to target different parts of our nervous system, both the parasympathetic and the sympathetic nervous system, and in particular, certain organs that actually will then, you'll manifest, or a person will manifest different symptoms based on the functions of those organs, or in this case, the dysfunctions of those organs. So historically, if you look at just autoimmune neurology, and I did a PubMed search where you can look at all the publications, and if you type in autoimmune neurology, what you can see over the last, let's say 20 years, you can see a huge increase in the number of articles, peer-reviewed research involved that's interested in and publishing studies in autoimmune neurology. There's several categories that fall under this, and I just briefly want to touch on it. So everyone's familiar with multiple sclerosis, which falls into an autoimmune central nervous system disorder, and it's very well defined and understood. We're not going to speak about that in particular. There are also autoimmune neurology disorders called paraneoplastic disorders, and para meaning alongside of, and neoplastic meaning cancer. Those autoimmune disorders that are associated with patients who have different types of cancers, and as the immune system begins to identify and fight off the cancer, in some cases what happens is they begin to develop antibodies against other parts of their body, such as limbic encephalitis and other types of paraneoplastic disorders. We won't talk much more about that. Then there are other types of autoimmune neurologic disorders called neuromuscular syndromes. Myasthenia gravis is one, and that is where the antibodies are actually attacking the neuromuscular junction and inhibit the movement of these muscles. And again, it's another autoimmune neurologic disorder. What we will talk about today, though, is the autoimmune encephalopathies. And there are various types, and there's more antibodies that are being discovered and identified that play a role, such as the NMDA receptor encephalitis, the voltage-gated potassium channels, the GABA, and in particular, we're going to talk about pandas and PANS. So you'll find many different categories of science and medicine are continuing to gain interest. Some may call it autoimmune neurology, others may call it neuroimmunology. You might see neuroinflammatory disorders and many other names. But basically, again, it's the intersection of the immune system and the neurologic system, and in conjunction with the neurologic system is the brain, therefore the psychiatric or neuropsychiatric symptoms. So these autoimmune disorders that we're going to speak about involve parts of the basal ganglia. And the basal ganglia in the brain is responsible for things like motor control, various types of learning, our cognitive functions, even our emotional functions, interestingly, even eye movement, and various types of functions that are executive functions that control different parts of our body. Another interesting and important fact is that two other disorders that are known to be disorders of the basal ganglia include Parkinson's and Huntington's, whereas Parkinson's is a movement disorder and is clearly identified now as an autoimmune disorder against certain targets in the brain. Whereas Huntington's has a copy number variation, which is a genetic issue, but also involves movement and the basal ganglia. So you'll see these different terms like infectious autoimmune encephalopathy, infectious autoimmune encephalitis, infectious autoimmune disorders of the brain, and again, referring to the trigger, in which we're going to talk a little bit more about, that these tend to be infectious triggers, but there are also believed to be environmental triggers. So just briefly, there's a couple of Danish studies that have identified a very strong correlation with infection, the immune system, and mental illness. And what you can see here is these two studies. One involved 4,500 individuals, and the other was about 3.6 million individuals. In the first study, what they found was that patients who had elevated interleukin-6, which is an immune cytokine, were more likely to be depressed at age 18 years, and that was increased by 55% over the population. And they also found that IL-6 baseline levels increased, or higher levels increased the risk of psychotic experiences and psychiatric disorders by age 18 by 81%. The other thing they found with the 3.6 million patient study was that if a patient was hospitalized for an infection, it increased the risk of having a mood disorder like bipolar or depression by 62%. And if a patient was hospitalized for an autoimmune disease, it increased the risk of a mood disorder by 45%. Whereas what they found, that if the two factors together were both being hospitalized for an infection and an autoimmune disease, the risk of subsequent mood disorders were 135%. So there's population precedent in showing that there is a connection, but we really want to look at more specific biology and etiology. If you look at publications over a period of time, you can see even in autism, which is a spectrum disorder, and it's categorized by certain groupings of symptoms, as which are most neuropsychiatric disorders. In these published studies, you can see that over 650,000 patients studied had a family history of some autoimmune disease. And so what you see is that there's this immune dysfunction, and which is a genetic predisposition, and then there's something that ends up triggering that. Another interesting study you can find, if you look even since 2012 when this study was published, that there was over 127 published studies that were demonstrating immune dysregulation in autism patients. Now, it's not to say that all autism is a result of an immune dysregulation. but there clearly is a portion of these patients who are diagnosed with autism that are involved with immune abnormalities. So kind of to summarize this a little bit is that this infection-immune-brain connection and its relationship to neuropsychiatric disorders can revolve around this axis, which I like to look at, that you have on one point these infectious and non-infectious triggers that can be bacteria, viruses, parasites, even environmental triggers. And then the immune system, in this case, which triggers the inflammation, the microglia activation, antibodies, mast cell activation, cytokines, and end up directing it towards the brain. Hence, you see these neurologic and neuropsychiatric symptoms. And it's all underpinned by a genetic predisposition with immune system dysfunction. And we'll talk a little bit more about this and how this actually is proposed in a mechanism of how this works. And then we'll talk a little bit more about the particular antibodies and then a bit more about the treatments. So we're not talking really about anything which is totally new. There is a long history of these infection-triggered neuropsychiatric disorders, and in 1894 rather, Sir William Osler described this bizarre and pervasive behaviors, which he called chorea minor, and he made that connection between the obsessive-compulsive disorders of these children and Sydenham chorea. And Sydenham chorea is abnormal movements, uncontrolled motor movements, as you can see here. But it was also termed St. Vitus's dance. It was characterized by these uncontrollable abnormal movements, this fine motor control loss of emotional control. And if you tie it back to what we talked about previously, the basal ganglia, again, the responsibility of the basal ganglia is the executive functions of those symptoms. This is also is triggered by group A streptococcus, or what we might think of as what we get with strep throat. And Sydenham chorea is the neurologic manifestation of rheumatic fever, which is in these patients with rheumatic fever. The strep, in this case, the bacteria, triggers antibodies to be made against it, but the particular antibodies that are made against a portion of the bacteria that cross-reacts with the heart valves. And hence, that's where rheumatic fever comes from. Of course, the treatment is penicillin or some antibiotic. And the other target in the case of Sydenham chorea is the basal ganglia, which hence results in these movement disorders. So if we look a little bit more about strep and the identification of what we call the epitopes, which are just the parts of the organism in which these antibodies are directed against. In particular, the ones that are cross-reactive are against what we call these group A carbohydrate or M proteins. And through a process which we call molecular mimicry, they then are made and directed against the basal ganglia, the heart valves, as we talked about in the case of rheumatic fever, arthritic types of complaints in the joints, attacking the kidney, and other parts of the body. So if you think about this, it's in wartime, we call this friendly fire. I'm not sure exactly where that term came from, but friendly fire meaning our own troops began attacking our own troops, and they use some of the strongest weapons that they have because they cannot differentiate between the enemy and our own troops. And this is basically the parallel to autoimmune disorders and what we call molecular mimicry. So this term molecular mimicry is really well established. and it is understood to be a precursor to many autoimmune dysfunctions. So if you look here at these neurologic or CNS conditions, Guillain-Barré, multiple sclerosis, Sydenham, chorea, and we mentioned myasthenia gravis, or asthenia gravis, in which the antibodies are actually attacking the neuromuscular junction, in particular, a receptor that we call the acetylcholine receptor. And you'll see the parallel when we talk about dopamine and dopamine receptors. These antibodies are directed against, in particular, a receptor that is involved in triggering the muscle movement. And so in these patients with myasthenia gravis, what you see is these inhibition of motor function and motor movement. Another similar type of mechanism in Guillain-Barré syndrome involves the attack of the myelin sheath around the nerves. And the myelin sheath is comprised of certain types of lipids of which we'll talk about lysoganglioside. And it does occur after different types of infections, but in particular, they see a lot occurring with Campylobacter. And then the antibodies begin attacking the myelin sheath, and you start seeing the wasting of the muscle tone, and then eventually the diaphragm and other motor movements in which a patient will no longer have motor control. So there are many others in this paper by Cusick. What you can see is they have identified putative, in many cases identified common epitopes of different types of autoimmune disorders that have occurred through molecular mimicry, of which a particular organism has been a trigger, or multiple organisms. Diabetes type 1 is understood to be an autoimmune disorder in which antibodies are attacking different parts of the pancreas and triggered by many of these different types of organisms. So with that as a background, we want to talk about Pandas. And Pandas is really just another manifestation of an autoimmune neurologic-based syndrome. And the acronym for Pandas is Pediatric Autoimmune Neuropsychiatric Disorder Associated with a Streptococcal Infection. And it was identified by Dr. Susan Sweeto back in the late 90s, where there was a first group of patients, in this case 50 that they identified, that had sudden onset of obsessive compulsive disorder that was preceded by an infection with strep. Now, she identified that there were other types of infections in other children that also had preceded similar types of symptoms, but they chose to focus on those that were homogeneous in symptoms and in a trigger, and hence the name Pandas and the criteria for Pandas. So in the yellow box here, this is what we just described as Pandas. But you'll also see many different terminologies like PITANs and CANs, and now the term PANS. And in 2013 is when the identification, and was published in 2015, that PANS, named as Pediatric Acute Onset Neuropsychiatric Syndrome, actually encompassed all of these other types of conditions or syndromes. So Pandas, with the S standing for strep, is included in PANS, and therefore that nomenclature is Pandas is a subset of PANS. I know it can be confusing, but the importance is these are the criteria which involve here is infection triggered, bacterial, viral, parasitic, fungal, and possibly environmental, that it is autoimmune, and that the immune is then dysfunctional, and it begins being directed towards a part of the body, in this case, the brain. The resulting symptoms are neuropsychiatric syndromes that have multiple heterogeneous symptoms, and this is part of the challenge with these disorders, whether it's in children or adults or whatever we would call it, is because it doesn't fall into these nice classifications where we can say all individuals with this have these symptoms. And this also makes it difficult in diagnosis. It is also directed against a portion of the brain. In this part, we've talked about various portions of the basal ganglia. And the criteria for PANS and PANDAS is this term acute onset. And it is important in the sense that the higher likelihood that all these patients with sudden onset, meaning almost like within hours or within a day or overnight or a couple days, it's pretty easy to identify versus what we see many times is maybe a gradual onset, where the immune system kicks in over several days, over several weeks. And so the research is still needed to identify, is this the same syndrome? But by definition, because PANDAS and PANS is a clinical definition and it's a clinical diagnosis, then these are the criteria in which the conditions are identified and diagnosed. So what are the symptoms and how do they get diagnosed? And it's estimated that 1 out of 150 to maybe 200 children in the US, which is where it's been studied most, is related to or has PANDAS or PANS. As you can see, the diagnostic criteria, it's pretty broad, but the first one is abrupt onset of OCD or restricted food intake. And restricted food intake can be sometimes maybe confused with anorexia, but when you're talking about a 4 or 5-year-old child, it's not likely that that's anorexia. In this case, it's really an OCD-like behavior in which individuals, or in these case children, believe that they have a food phobia, a fear of contamination, a fear of choking, a fear of throwing up. So basically, the first criteria is abrupt onset of OCD or severely restricted food intake. And then having 2 of the following: anxiety disorders, emotional ability or depression, irritability, aggression, oppositional behaviors, developmental regression, deterioration in school performance. As you can see on the right panel here, one of these children who was drawing when they had PANS or PANDAS, and then their ability to draw afterwards. These could be confused with ADD and ADHD symptoms, memory deficit, cognitive changes. You'll see sensory or motor abnormalities, somatic signs and symptoms, inability to sleep, bedwetting, enuresis, meaning a 9 or 10-year-old child now starting to wet their bed. This has to do with a sphincter that's being controlled by that part of the brain. And then again, symptoms that can't be explained by other neurologic or medical disorders. So essentially, this is a rule-out disorder in that you're looking for, are there any other possible explanations for it? And then you look at here the heterogeneity of these symptoms. It does make it quite difficult for this to be clinically identified and observed. But that's where it's very important, because patients that do have these conditions, when properly diagnosed, can be treated, and you can see very, very remarkable recoveries. And the age at onset tends to be prepubertal. You see 6.5 for plus or minus 3 years for tics, and 7.4 for OCD. And in this case too, boys outnumber girls 2.6 to 1. So at the National Institutes of Mental Health, where these were studied and where Dr. Suida did a lot of her work, that the symptoms during these exacerbations can range to bedtime fears, school changes, distractions, frigidness, choreiform movements, and then often you can see these comorbid diagnoses. So whether it's things like ADD, ADHD, depression, anorexia, and again, you can see how difficult this can be, and which makes it a little challenging when there are children, and we'll talk a little bit about adults towards the end, but when individuals present with various types of symptoms such as these. So what's the mechanism, and what's at least understood is how this occurs? We talked about the infectious part of it, the microbial, viral, fungal infections, of which we all get. We all have an immune system that fights these off, and our body does what it needs to do, and it generates antibodies against these organisms. And we do this every day of our life, and many times we don't even know it because it's warding off infections silently. In an interesting analogy is when people with HIV technically really don't die from HIV, they actually succumb to these nosocomial or these common infections that typically normally healthy immune system individuals would ward off every day, whereas an individual with HIV and a weakened immune system is unable to mount a response that would protect them from these nosocomial infections. In these patients, the antibodies in which they choose to make, or their body choose to make, which is in genetic terms a random process, but there is a screening component that goes through the thymus in which the body tells the body what's self and what is non-self. And in this case, there's something that goes awry, and through molecular mimicry, those particular antibodies then are pushed out into the system. And in these cases, they are directed against the brain. In particular, we talked about the basal ganglia, and in a analogy to friendly fire. Hence, then, you will see these symptoms and various types of symptoms in different individuals. So Dr. Cunningham, my collaborating co-founder, has published extensively on the biology of this, looking that these antibodies actually cross-react with the parts of the basal ganglia in Pandas and Sydenham, chorea, and you see the purple staining indicates that these antibodies are binding to these parts of the brain in the basal ganglia, whereas in the control individuals, they're blue and not purple, and therefore they are not binding there. In another publication in Nature Medicine, looking at both these antibodies binding, but also we'll talk a bit about the calmodulin CAM kinase, which is an enzyme that is responsible for the upregulation of three neurotransmitters, dopamine, epinephrine, and norepinephrine. And so these antibodies were able to trigger and bind to the basal ganglia in SC or Sydenham, chorea, but also were directed and were against these gangliosides, which are different types of lipids that are involved in the myelin sheath. So the panel that we run and test here is called the Cunningham panel, named after Dr. Cunningham. And it is a panel of 5 different tests. And these 5 tests are run, and we identify in the first 4 antibodies that are directed against these particular targets, particularly those that are concentrated in the brain. And then the 5th one, which we'll talk a little bit more in detail, is one that is the CAM kinase. It's a cell stimulation assay. We've tested now over 8,500 patients in the US and in other countries. And one of our doctors, Dr. Amram Katz, is now actually tested over 250 patients. And he's identified, along with some correlation that we do see, is that patients that predominantly are positive with dopamine D1, meaning their antibodies are highly positive, they're directed against the dopamine D1 receptor, that they often have psychiatric symptoms, including psychosis. In those patients that have antibodies directed against the dopamine D2L receptor, they find they're often positive with different type of movement disorders and impulsivity. In those patients that only have anti-lysoganglioside GM1, which is often positive with these neuropathic symptoms, including tics, and again, remembering lysoganglioside and these gangliosides involved in the myelin sheath, which protect the nerves in which the electrical transmission transverses. In the anti-tubulin patients, or antibodies directed against tubulin, they often find that they're positive with patients who have cognitive complaints, like OCD and brain fog. And tubulin is identified and located in every cell in the body, or every structural cell in the body. But it's also known to have a role in other types of biological functions, which we'll talk about also in a minute. And then the CAM kinase activity, which we'll talk about a little bit, is involved with involuntary movements and adrenergic activation. It is cell stimulatory activity that we measure. In other words, can an antibody stimulate this enzyme to be upregulated and do what it normally does, which is make more dopamine, epinephrine, and norepinephrine. So let me show you a few case studies. We have hundreds of these now, in which patients were tested prior to treatment, then treated, and then tested post-treatment. In this case study, we see a 24-year-old male. The presentation was obsessive compulsive disorder, motor tics. He had lost 30 pounds. Again, could have been confused with anorexia, but inability to concentrate, these other symptoms, emotional ability, behavioral regression, etc. And his panel is there. The CAM kinase was significantly elevated. And this is part of the reason that we do run all 5, is because we do not know ahead of time which markers would be or could be elevated. And we believe and are working on the connection between these and symptoms, and potentially future opportunities for these and optimal treatment. The patient had been treated then with 1 intravenous immunoglobulin and plasmapheresis. His symptoms completely reduced. He was retested, and his CAM kinase went back into baseline. Another young girl here who had obsessive compulsive behaviors, verbal tics, and the stimming behavior, which is an autism-like behavior. She had trouble concentrating, emotional ability, urinary and sleep problems, the dysgraphia, which showed previously the inability to draw, and this relapsing and remitting nature of the condition, which is characteristic of Pandas and PANS. And in her situation, there were 2 positives. One of them was the lysoganglioside antibodies and anti-tubulin. And I believe this one may have had a recent strep infection, or one that was undiagnosed because she may not have had symptoms. It was identified, the patient was treated with azithromycin, complete and rapid improvement in symptoms. Patient was tested and all of her antibodies returned to baseline. I'm just going to show you 2 more and then we'll move on. Another 9-year-old girl was presenting with unknown origin of neuropsychiatric symptoms. This patient actually was diagnosed and did have Lyme disease, positive by a Western blot. And her chief complaint was, "Mom, something's happened to my brain." And you can see here 3 of the antibodies were positive and very strongly positive in one of them, the dopamine D1, the D2, and then the anti-tubulin. She was treated for the Lyme, which often is challenging to treat with azithromax, naproxen, Omnicept, Bactrim, and then also 3 IVIG treatments. She had complete symptom regression, and you can see upon retesting, her panel is all back into baseline. And then one last one here, a 9-year-old boy who presented 30 days after a strep infection, had OCD, tics, couldn't concentrate. Again, you see the emotional lability, separation anxiety, developmental regression, et cetera, et cetera. And this one, he had 1 positive, which was the CAM kinase assay. In this case, the patient had intravenous immunoglobulin also, and not all of them do, but some of these may have been a bit more aggressive, and they do respond within 1 month. Had complete symptom elimination, and you can see the CAM kinase resolve back to baseline. And so let me just share with you how the biology of these targets impact that. So in the test 1 and 2, which I mentioned about the dopamine D1 and D2 receptor, what you see up here, this little globular looking type of, it's a receptor in the lipid bilayer of, in this case, brain cells. These dopamine, they're the dopamine transmitters, are pre and postsynaptic, where they identify and they continue the impulses from one cell to the other. Dopamine D1 and D2 are highly concentrated in parts of the basal ganglia. In particular, you can see here in the globus pallidus, the putamen, the caudate nucleus, and those are the parts, again, that are responsible for what we discussed in those different symptoms. The issue is that in these cases where antibodies are directed against these receptors, as you can see here with the antibodies, and then of course these green blocks just representative of something that fits into it, they can either act as an agonist, and an agonist is a substance that initiates a physical response. So basically, some of these antibodies can act like drugs, and they can actually stimulate the dopamine receptor. Whereas other antibodies that people may make actually could block or interfere, and they would have different symptoms because they would be blocking the dopamine receptor. And hence, you can see different types of symptom correlation. The third test that I mentioned was the anti-lysoganglioside GM1. And as you can see here on the right, a nerve cell, and these yellow insulators, which are based out of myelin, the myelin sheath, but also of these gangliosides. And as mentioned with Guillain-Barré syndrome, the antibodies attacked them and began to demyelinate them, and you see the wasting syndrome. This is another type of a ganglioside that we test and identify that's involved in certain parts of neuronal cells in the brain. Then the fourth one, which is the tubulin, but tubulin, if you're familiar with it, it actually is believed to be, or was believed to be, just a scaffolding protein that holds cells together and kind of keeps their shape. Whereas if you see here on the right, these are different studies in which they found mutations in tubulin, and they found that these patients ended up with ALS, autism spectrum, dystonia, basal ganglia defects, microcephaly, many neurologic and dysfunctions here. So what we find, particularly from a clinical standpoint in our population, as I mentioned, that we do see OCD and cognitive impairment often associated with anti-tubulin antibodies. And you can see aggressive or rage behavior and many of these different symptoms that may be particularly associated with this particular antibody. Then there's the fifth test, in which we call the calmodulin cam kinase. This is a cell stimulation test. As you can see on the left, the identification of this neuron in the brain. There's a pre and a post synaptic neuron, and the dopamine transmitters or dopamine neurotransmitters empty from the presynaptic terminal, and then they bind to a receptor called the dopamine receptor, D1, D2, and then once they trigger it, then the electrical impulse continues. And so when you see in Parkinson's disease, a lot of this is, it's not completely understood, but it's also known that certain types of things that improve this dopaminergic type of activity improve patients with Parkinson's. But in this case, we're talking about actually an antibody that binds to the cell, and it inhibits, or not only can it inhibit the dopamine receptors, but by binding to the cell, it stimulates cam kinase, and cam kinase, when it's stimulated, produces more dopamine. So here you have an antibody that's telling the body to produce neurotransmitters. And as you can see on the right, you can see in Sydenham, chorea, or SC patients, very high activity. They have uncontrollable abnormal movements, motor movements. Pandas patients, moderately so, and then non-Pandas patients, which are around baseline. So thinking about what are those infectious triggers, and hopefully everybody's not now afraid that if we get an infection, we're going to get Pandas or PANS or some neuropsychiatric disorder. These infections, though, are known to be and have been associated with these disorders, but it doesn't mean that everyone that gets these will end up with these disorders. And that's part of the controversy with Pandas is, why does 98% of the children get strep infections and only 1 in 150 or 1 in 100 or 1 in 200 patients get PANS or Pandas? Again, it has to do with the immune dysfunction component, that an individual is making the wrong antibodies. We see it with influenza A, varicella, mycoplasma, Lyme, Babesia, Bartonella, Coxsackie virus, and typically patients have more than one infection and it can be subclinical. So I'm going to quickly run through a couple of these things so I can get to the end here and then let you ask questions. This is a study that we conducted of 62 patients. There were 206 who had 2 tests, pre and post. We separated the 62 into patients who got well or improved, group 2, patients who didn't get well or got worse, and we wanted to find out what was the correlation with their antibody titers and their symptoms before and after the treatment. So here's a heat map of all the patients who improved, but what their pre-treatment results look like. The red shows that they're strongly positive in the CAM, lysoganglioside tubulin, D1, D2. They were treated. This wasn't a treatment study, but they were treated with various treatments. And these that got well, as you can see, the vast majority of the patients, their antibodies went back into baseline, were greatly reduced. And you can see the blue compared to the orange is the number of positive tests in these patients. If we look at the patients who did not improve or got worse and what were their antibody titers prior to that, they did have still high antibody titers. Interestingly, not all of them were positive, but they even became, when they became worse or didn't improve, many of their antibody levels actually increased. And so the patients who did not improve demonstrated high antibody titers. Patients who did improve demonstrated lower or resolved antibody titers. And there's no statistical difference between their ages or the time between their tests. And we saw the same results with the CAM kinase assay. Group 1 that improved, overall reduction of all their activity. Group 2, no statistically significant difference. When we looked at the sensitivity and the specificity of the panel, and we identify, was there a symptom correlation to positive test results, we see that there was an 89% sensitivity, 84% specificity, and an accuracy of 87%. And if you look at the receiver operator curve, which is just identifying the population of patients that correctly were identified, and you see the dotted line, which is random. Anything above it indicates that it's correctly identifying. And you can see the number of patients going positive to negative, group 1 versus 2. And then we compared it in one other way, looking at not the cutoff, but what's the magnitude of change in the patients, their results. And with that, we got a similar sensitivity of 92%, a specificity of 88%, and an accuracy of 90%. There are also a couple other published studies that came out, which is very interesting. Related to autism, Dr. Richard Fry studied 82 patients with autism and identified 49 out of those 82, or 60%, had some autoimmune antibodies. He was then able to treat with intravenous immunoglobulin 36 of those patients. And after they were treated, he looked at the responsiveness and compared it to the panel being able to predict it. They found that 81 to 88%, the panel predicted the patients who would respond and improve to immunotherapy. And one last study here, a patient diagnosed with schizophrenia over at Cincinnati Children's Hospital. This patient was a 15-year-old girl who had been diagnosed and treated unsuccessfully for schizophrenia and had psychosis, severe anxiety, and depression, in and out of treatment facilities. Her antibodies were very positive. The immunologist ordered 1 plasmapheresis. The patient had complete resolution of her psychotic OCD and anxiety symptoms. She was weaned off of olanzapine, and within 2 weeks, she was back home, and we talked to the physician. She's playing tennis, and we ran a test on her afterwards, and everything was back to normal. The good thing is there are treatment guidelines. In the JCAP journal, the PANS physicians group has put together a very nice set of baseline guidance, treatment guidance. This is going to probably continue to evolve, but if you're interested, that's something that we or AONM can send to you. And typically the treatments fall into these different categories or buckets: anti-infectives, anti-inflammatories, immune modulators, and even effective allopathic, integrative, or natural treatments also fall into these categories. So the good news is there are treatments, and more treatments will be coming out. So in summary here, I'm going to share with you something I adapted from Dr. Sidney Baker called the TAC laws. The first TAC law is here: if you're sitting on a TAC, the treatment is not 2 Advil every 3 to 4 hours. The treatment for TAC sitting is TAC removal, and the corollary is search for the root and treat the cause rather than the symptoms. The second TAC law is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms. Complex conditions are complex, and to be effective, you have to address all the issues for resolution. So correctly diagnosing patients for the root cause with neuropsychiatric symptoms is really essential in order for treatment. The other problem is that most of these, and probably all of them currently, are diagnosed by symptom clusters. And when they identify symptom clusters, they're put into these different diagnostic categories and many more. But unfortunately, these are deemed incurable. So there are many chronic disorders that can have a segment of a patient populations caused by an autoimmune etiology, and it's really important to identify the root. So the Cunningham panel can be an aid in the physician's diagnosis of Pandas or PANS or other autoimmune encephalopathies, and AONM has doctors in the UK that can prescribe and order the panel. The second important piece is to locate a doctor who's open to working with patients having autoimmune neurologic disorders, and they can prescribe the panel. So in closing, what's the key to change in reality? Is one, we have to increase the awareness of autoimmune neurologic disorders. This is not just in children, but also in adults. And this is really one of the things I appreciate about AONM, is that they are doing this and they're getting education out there. They're also doing the second part, which is more education about the biology of these conditions. Third is more research and clinical studies to better identify the etiology and discover more efficacious and targeted treatments, which we are doing here at Molecular Labs and many other institutions around the country. And the last one, if you're a patient, or if you're a parent, or if you're one suffering from these, is perseverance, because at some point, what might seem impossible really becomes possible. So if you think about many other disorders, including things such as peptic ulcers, which was thought to be just caused by stress, it was identified to be caused by a bacteria, Campylobacter or Helicobacter. And in the beginning, it was thought that this individual was crazy, till they now know and routinely test for that bacteria when you have a peptic ulcer, and the therapy is antibiotics. And we believe that over time and perseverance, that Pandas, PANS, and many of these other autoimmune neurologic disorders will be the same, that they will identify them very quickly, patients will be treated effectively, and we'll not see many of these autoimmune neurologic disorders that last for a long time. Here's some additional resources, and there is the places in which you can contact a whole host of different resources. And I look forward to answering questions. I typically, unfortunately, can do that is go too long, but I hope that there's time for questions.
Thank you very much, Craig. That was absolutely fascinating, and largely a new field for us here in the UK, must admit. Overall in Europe, we don't have the many years of experience that you do in the States, so we can learn a lot from you. Thank you. Just a couple of questions that I'd like to try and get in before past. I believe we do need to finish on time, more or less, today, but we'll answer all the other questions afterwards. We'll probably need to start a bit of a blog and have you working with us on that, Craig. Okay. So one of the questions is, would you recommend plasmapheresis to a young adult who has not responded to IVIG?
Mm-hmm. So good question. And again, I have to make a disclaimer. I'm a scientist and not a practicing physician. But I would say that there are many that have, when they have not responded to different types of other therapies, have found success with plasmapheresis, because the premise of plasmapheresis is that it removes immediately all the antibodies that are there. If the antibodies are the root cause, then patients, as you can see with the schizophrenia patient, rapidly improved. There are other things to consider, because always there's risk with any treatment, but depending upon the severity, often you will see that that is one of the choices that many of these practicing clinicians will go to.
Thank you. And then another question is whether you could outline, or at least give us a little insight into, some naturopathic treatments that doctors over in the States have been having success with.
Yeah, that's a great question, and it's constantly actually evolving. I would say that it falls into those same categories. So whether it is allopathic or naturopathic, you will see anything that modulates, impacts, influences the immune system, strengthens the immune system, anything that decreases inflammation, which is why steroids are used, But there are other things that will decrease inflammation, including naturopathic remedies. And anything, in many cases, there are infectious organisms, and more than one. So anti-infectives, anti-inflammatories, immune modulators, and things that play those role. We find it interesting that the gut is also plays a role, because there is an interaction between the gut, and 2/3 of the immune system is in the gut. But as to specific types of things, I would think, well, you have other people that I think will come on and can speak more directly to specific treatments. But in general, if you think of those categories, those are the ones that are also used in allopathic medicine.
Thank you. Could I just mention that we feel very privileged to have Dr. Sam Yanuk speaking to us on the 12th of May, when we have a conference which is in Invisible Diseases Week in the UK, and we'll be focusing on ME and fibromyalgia and these kinds of conditions that have no clear cause and are often fobbed off as being neuropsychiatric. We'll be hearing from him the kinds of naturopathic treatments that he's been using very successfully over in the States. He's got a huge following, hasn't he? And he's seen many thousands of patients.
Yes.
So please look at our webpage, AONM, and our events, and you'll see the 12th of May, that's a Sunday, it's here in central London. And then another question here, would low-dose naltrexone help, being an immune modulator?
Yes. So again, referring to what we've observed, there are many patients who have used LDN, and they have seen good responses on that. It depends also on other things that the patient has tried. If they have an infection and they haven't treated the infection, you might see some improvement, but maybe you won't see complete improvement. Again, it's an effector of different types of receptors in the brain, so it would make sense. And again, those are some alternative therapies that other clinicians have found to be successful in certain cases with certain patients.
Thank you. Well, we will be having further seminars with you, Professor Shimasaki. We've planned a series of 3, so we will let everybody know when those are going to take place, and possibly even have you on together with, for example, Dr. Yanuk or others. That would be wonderful, wouldn't it? So that in terms of the treatments, I know it's a little unfair to be piling on those questions. But one other question that's come in is, will the Cunningham panel test evolve over the next few years?
Absolutely. And we are currently looking at a couple of other targets, like the serotonin receptors. We believe that they may account for additional parts. We have about 24 other markers. And the other is that we are using machine learning to try to take the 8,500 specimens we have, and the knowledge from the patients that got well and those that didn't get well under certain treatments, and produce an algorithm that would then be a part of the test. So when a patient would get a test, then their panel would predict the algorithm, through the algorithm, what treatments might be most effective, so then the clinician could be able to then take that information and not have to trial and error as much, but maybe identify certain treatments that have been most effective for that type of patient profile.
Well, that would be absolutely fantastic. What's the time frame on that, would you say?
We're actually working on it now, and everyone who does send in a test, and if you do, we ask that we get an informed consent so we can keep your specimen and that we can contact you in the future. That helps us with research, because we now have over 8,500 of those specimens. And as we develop and identify other types of tests for different types of disorders that are autoimmune, whether it be things like chronic fatigue, maybe bipolar, chronic depression, other things, we believe that these targets and these markers will have different types of relevance to that also.
Thank you. Could I just mention, Craig, that AONM has kindly been given a dispensation in terms of what you said earlier, that it had to be a physician who prescribes the test, because that's a learning curve here in the UK, and we don't yet have as many physicians as we'd like who are aware of it and able to. We do have a means whereby even non-physicians can prescribe this test, and then often small teams begin to build around the patient depending on what's found. And there is now the Children's Hospital, which is specializing in Pandas, but they do only see children, and so the problem is the adult patients with conditions. So
those are important distinctions, if I can comment on that. Yes, that's good, because as long as there's a provider who can work with the patient, we are also happy to help. The other is about children versus adults. Children grow up to be adults. And so many of these patients who were PANS or PANDAS or autoimmune end up with being adults with these. And there are some later onset. So most of what we talked about will apply to individuals at different ages. There might be slightly different issues that they may face, but it is important to remember that this is not necessarily a childhood syndrome.
Okay, well, thank you very much. One further mention is that there are additional presentations up on our website. If you look at events, you'll see that we had an event with Moleculera last May, and the presentations are there and all downloadable, and also the recordings are available. And then we had a conference, that was our 2018 conference, where Dr. Madeline Cunningham spoke, and we have her presentation and recordings up on the website too. So do have a look, please, at the AONM 2018 conference for that. And hopefully, Craig, we'll have you over again soon.
I'd be delighted. Yeah.
Helping to educate us on these very, very pernicious and difficult to treat conditions. Thank you so much. That was great. And further questions have come in, so we'll be sending them to you and asking if you wouldn't mind answering them. And we'll be sending out this recording and the slides to everybody who registered for this. And so thank you so much.
Thank you, Jillian, and I appreciate all that AONM has done to help educate, and we'll be happy to support you in any way.
Thank you.
Thank you.
Goodbye then.
Bye-bye.
Bye-bye. Thanks.